Dear friends, during last 12 minutes, what you heard from Dr. Jayan Panda, who is my friend, but for this 30 minutes, we are going to debate on a scientific platform. Remember three things he said. First, variability of glucose. He showed a beautiful CGMS chart is a big challenge. He showed that inadequacy of treatment is well identified in type 1. And in fact, last 3 minutes he spoke about what I had to speak, other drugs in type 1 diabetes. I was wondering what he interpreted in the title. If you read, Insulin be the sole therapy? Not anymore. Probably I feel so sorry that somehow interpreted differently. I am not paid by any company, and all thoughts expressed here are scientific evidence based. He made a mistake in interpreting same two slides where 10% beta cell function remaining is a difficulty, it's a challenge. Rather, that itself says we need to have alternative. He has a very narrow vision and cannot see anything other than insulin. 94 years of insulin, we still talk about so-called DCCT, which had 3 to 5 injections, required pump, frequent SMBG, up to 7 blood glucose, and monthly visit, telephone contact. These are all challenges. Studies and results are not replicated anywhere. Leave aside a lack of patient in India and Southeast Asia, what he mentioned. In our clinic, in our patient, all those things cannot be achieved. We have kind of conventional treatment. This is what happens in most of the people. We hardly reach closer to intensive group. Look at a complication rate which is there in conventional and intensive in both the group. So they remain a challenge, and we need to look beyond insulin and not remain on insulin. Many agents have been found to be useful. You have to plan, have a strategy, make an effort to find out a new solution and not remain wedded to the old insulin. Why alternative? Because type 1 people are not children. They grow into puberty, adulthood, develop obesity. They consume meals, they consume same large carb loaded meals. Gastric emptying and intervention offers one of the solutions to look after those prandial glucose spikes what Dr. Jayan has shown. Type 1 diabetics have truly, as it is shown in this study, hypertension and metabolic syndrome. They do have all these problems. Let's go systematically for other drugs. Metformin study reduces insulin dose in type 1 diabetes, and there could be on long term benefit in cardiovascular and other outcomes. This is another paper in Diabetes Care which showed that in uncontrolled patients who were taking insulin approximately 0.7 unit per kg, 7 out of 31 patients, that is 23%, who responded to metformin, and they had 20% reduction in insulin requirement. There had been 19 events in metformin group and 8 events of hypo in placebo group. That itself says that metformin is efficacious. If you see this graph, you have a total insulin dose needs, insulin basal rate and insulin bolus rate, all of them improve with metformin. So, in this editorial, in Diabetes Care, there is suggestion that small subset of type 1 diabetic would benefit with metformin. It's not only metformin, but there is a paper on rosiglitazone where 50 type 1 diabetics with BMI more than 27 were assigned to rosiglitazone 8 mg per day. And in all these patients, you can see that glycemic control from 7.9 to 6.9. You have 1% reduction in A1C, and compared to increase in the insulin in the placebo group, there is a reduced requirement of insulin. So rosiglitazone also works. Pioglitazone has been shown by my friend Dr. Jayan. You have seen those data. So in short, rosiglitazone, pioglitazone and metformin all could be effective. Let's come to very important drug to minimize glycemic variability. This is a paper from Priscilla Hollander and a group who has looked at A-cargos in treatment of type 1 diabetic. And this was 50 to 300 milligram forced titration was used over a period of 36 weeks. And you can see an A1C reduction of close to 0.5%. No difference in incidence of hypoglycemia, and it could be used simultaneously with insulin what is being used. 32% in A-cargos group were successfully treated. So all your postprandial glycemic peak and variability could be managed with concurrent A-cargos. Rather, using A-cargos at night could minimize nocturnal hypoglycemia. If you look at glycemic variability, there is a benefit. If you look at a retinopathy which is associated with glycemic peak and not represented by A1C, also would benefit with A-cargos along with insulin. This is what has been come out in DCCT, that hardly there was a difference in retinopathy. And you can see here 0.63% A1C reduction with A-cargos would probably reduce progression of retinopathy by 25%. The next one is amylin, is deficient in type 1. Again, my friend Jayant has shown this. Pramlintide is an amylin replacement drug. There is a paper in Metabolism, and the authors and investigators have concluded that mealtime pramlintide prevents abnormal meal-related rise in glucagon, an effect that prevents or rather improves postprandial homeostasis of glucose and long-term glycemic control. So I have A-cargos, I have bio, I have rosi, I have metformin, I have amylin. Let's go beyond. ADA has recently published that SGLT2 works in type 1 diabetic as an add-on. There is a paper last year published in September 2014 on DAPA, and you can see the design. 4 different doses of DAPA were evaluated. Focus on 10 milligram, which is in the market, what is going to work. On the left you have a change in urinary glucose, change in fasting, change in standard deviation of daily glucose. On the right you have a 7-point glucose, daily average glucose, and a MAGE, which you have learnt in a previous debate. This is glycemic variability. And on the right point, which is 10 milligram dose, all across there is a benefit in all glycemic parameters with the basal, A1C or MAGE. If you look at insulin requirement change with SGLT2, you have practically no change in basal, but there is a reduction in prandial, and there is a total dose which has reduced. So in short, DAPA SGLT2 has a potential to benefit type 1 patients by reducing decrease in the insulin dosage and taking more people to a good glycemic control without putting any load on beta cell, without causing any hypoglycemia. If you have to look at incretin based therapy, we are not looking at increasing insulin or beta cell mass, which we don't know it would happen or not. We will have to wait for a little time. But incretin based therapy, if administered, can reduce peak postprandial glucose by 45%. Look at this paper which is published on April 9, 2 days back. A counter-regulatory response to hypoglycemia in subjects with type 1 diabetes with liraglutide given for 4 weeks. And you can see here, these are with similar BMI, age 34, A1C of 7.6, 16 years duration of diabetes, and they underwent a CLAM studies. In results, there is greater reduction in insulin dose and body weight seen with liraglutide compared to placebo. Glucose infusion rates were significantly lower compared to placebo. So we have an evidence that liraglutide works in type 1 diabetes. Look at another paper, a study which is designed, again published in BMJ this month, that efficacy and safety of GLP-1. This is an investigator-initiated double-blind trial which is going to look at much beyond glycemic control. Look at these secondary endpoints: change in insulin dose, hypoglycemic events, body weight, lean body mass, fat mass, food preferences, adverse event. You forget that you are managing type 1 diabetic. Insulin remains and A1C remains in one corner, but you have to make a change in all this. This is what we are looking at. Finally, there are many other potential targets for treatment and intervention in type 1. Don't remain with insulin alone. There are monoclonal antibodies. Many of them have been evaluated. Look